Okay, can we start, Rusil? Okay.
Yes, sir. Please.
Yes. Okay, thank you. Yes, good afternoon, friends. I, Dr. Pragnesh Shah, President of Federation of Family Physicians Association of India, welcome all the esteemed speakers and delegates across the country. With us, Dr. Darbar Sahib, he is a very active member of the IMA CGP, Dr. Pragnesh Vachharajani, Secretary of FFPAI, two very elegant speakers, Dr. Urvesh Shah and Dr. Vipul Shah with us. Today we will first start with the decoding the H3N2, the microbiology section. And for that, we have very learned speaker, Dr. Urvesh Shah. He is a professor and head of the department of GCS Medical College and Research Center, Ahmedabad. And he is a member secretary of the Ethics Committee and Scientific Research Committee of the same college. And he is very active in Indian Medical Association, vice president of the IIM Ahmedabad branch, and standing committee member of the social media IIM headquarters. Now I request Dr. Urvesh Shah to take a charge. Dr. Urvesh Shah.
Excuse me, Urvesh bhai. Before you take up the mic, I would like to share my views about the College of General Practice.
Yes.
See, dear friends, College of General Practice is a subsidiary of Gujarat State Branch IMA, and it works in every state. From this year onward, we have started to make this College of GP active for two reasons. First thing, nowadays the general practice is decreasing day by day, and the diseases which are coming up in the general practice has now changed almost 360 degrees. Previously, we were looking after this few very infective cases and all that, and nowadays we are coming with all new viruses and non-communicable disease like hypertension, diabetes, blood pressure, and everything. And after corona, we see lot many thromboembolic phenomena in young patients also. So we want to sensitize and we want to make aware all our general practitioner faculty across Gujarat by this platform. And routinely we will be doing this sort of program either online or offline. So we request all our family physician members to look our whenever we send any WhatsApp or any invitation, kindly join and get yourself abreast with the new clinical knowledge. Thank you. Now over to Urvesh bhai.
Thank you very much. Dr. Pragnesh bhai, President, Dr. Pragnesh bhai, Secretary of the Federation Family Physician Association of India, Darbar sir, and CGP IMA GSB. As I know, the major part of today's audience for today's webinar is a family physician. Perhaps you are the largest experienced community for management of the seasonal flu. In other way, I can say, perhaps the seasonal flu is the most common clinical presentation you have ever encountered during your entire practice. So you know lots of the things about the influenza, seasonal flu. But today I am given responsibility to explain something about the basic concept about the influenza virus, the nature of the virus. Because it is very important. If we know the nature of the viruses, the basic concept of the viruses, then only we can interpret properly the epidemiology, the clinical significance, as well as the management aspect of the diseases. The first about the influenza virus. It is a member of the Orthomyxoviridae family, Orthomyxoviridae and Paramyxoviridae family. If you are knowing, I am just refurnishing your knowledge, what you have studied in the MBBS. And the orthomyxa includes the influenza, paramyxa includes the parainfluenza and the measles, mumps. Majority of these viruses affects the respiratory tract. Now, important to know about this virus, it is enveloped It is important thing. Second is negative sense. Perhaps you have heard about the negative sense in COVID also. The negative sense is nothing but this virus RNA when enters into the human cell. First, they require to be converted into the messenger RNA. Then only this mRNA will encode the viral protein. That is the negative sense. It's not so much important, but it's just a molecular concept. It's a single-stranded RNA virus. What is another thing which is important? This RNA is a segmented and having 8 segments. Remember, this is a quite important thing by which you can understand its a epidemiology, it's a pandemic and epidemic nature of this virus. As you know, there are the 4 genera out of which A, B, C are the human influenza viruses, while the D only infect the birds. Out of A, B, C, influenza A, they are the most common, and perhaps what we are usually encounter problem is with the influenza A. The major pandemic are of influenza A only, and many of the outbreaks of the seasonal flu are attributed by the influenza A only. The influenza type B is also common. There are the certain outbreaks we have noticed, and many sporadic cases also we have noticed of the influenza B. But the influenza C is very less common, so epidemiologically less significant. Now, something about the virus. This is the virus, approximately 100 to 120 nanometer size, very small to be visualized under routine microscope. We need the electron microscope to be visualized. The fourth component is important to remember. Again, it's the envelope. The envelope is having the transmembrane protein, 2 transmembrane protein. This is the heme agglutinin. This is the neuraminidase. And fourth important thing is its RNA. RNA is a segmented RNA. You can see here there are the 8 segments into the RNA. Out of this, the sets of the 6 segments, they are specific for the human host. But what is important for us to remember, there are the 2 segments, HA and NA. HA is encoding the heme agglutinin, this H antigen, and NA, which is encoding the neuraminidase. These 2 segments, defines the not only the host specificity, but also they are responsible for the many pandemics. Now, something about H and N, because we have heard about the H1N1, H3N2. So, what is the H and what is N? They stand for the heme agglutinin and neuraminidase respectively. Heme agglutinin means they are having ability to agglutinate the RBC, and neuraminidase means they are having an enzymic activity to degrade the celic acid. These are encoded by gene, as I already have mentioned, the HA gene and NA gene. There are the 2 segments out of the 8 important segments of the viral RNA. Now, this out of 2 H and N segments, you may observe the different types of the H antigens, which are approximately of 18 subtypes. Just name as H1 to 18. But any virus can have only one subtype of H antigens. And out of this 18, in any of the human virus, you can see the any one of this 6 subtypes. So human virus can have only H1 or H2 or H3 or H5 or H7 or H9. Similarly, there are different 11 subtypes of the N antigens. Out of this, only 2 can found in human. So either in human or human influenza virus, you can see the N1 type of the antigen or N2 type of the antigen. And as already I have mentioned, each virus contains any one type of HA and any one type of NA antigen. For example, H1N1, swine flu, we have heard about that. That contains H1 type and N is also 1 type. We have heard about the avian flu, that is H5N1, means it has H5 type and H1 type. So, each combination of the H and N antigens are entirely distant and can cause a new pandemic. So far, as already I have mentioned, there are the 18 H antigens and 11 N antigens. So hypothetically, theoretically, there could be a 198 combination, H1N1, H1N2, like so on, 198 combination, but is here it's it is important to remember, as already I have mentioned, only 6 variety of the H antigen can found in human and 2 variety of N antigen can found in human. So again, hypothetically, only 10 varieties of the influenza A virus can be seen in human. Out of this, very few are evident, like H1N1, H2N2, H3N2, H5N1, etc. Now, out of this H1N1 and other different combinations, we have observed the certain pandemic. We have our globe has been hit by the certain pandemic since long, since because the history of the influenza is more than a century old. As you know, in 1889 to 1890, there was an outbreak. It was presumed due to an influenza. We know very well about the Spanish. We have heard about the Spanish flu, which trolled almost a 5 crore of the people worldwide. That pandemic was in 1918 to 1919. Again, it's a very important to remember. See, it's a very interesting thing. At that time, we were not knowing about the virus because we came to know about the virus only after the invention of the electron microscope. That was around in 1933. Only after that, this retrospectively, this virus of the Spanish flu was characterized, and it was characterized as H1N1. Later on, if our globe has observed this pandemic, 2 more pandemics, the H2N2 of the Asian flu and H3N2, which is known as a Hong Kong flu, which was observed in 1968 to 1969. And recently, a very huge pandemic hit the world again in 2009, 2010, and then onwards. That is the H1N1, novel H1N1 swine flu. Apart from this pandemic, these were the pandemic. Apart from this pandemic, several outbreaks also we have observed. That is in around 1900 to 1903. It was a moderate kind of the epidemic. It was not a pandemic. 1930 to 35, again a pandemic, and so on. But it was consistently observed that, see, H3N2 is not newer one. It is consistently observed after 1978. In every alternate year, the world has suffered from the outbreak of the seasonal flu, right? So it was very periodical. Either it could be a H1N1 outbreak or H3N2 outbreak, or it was mixed. But at every alternate year, it was observed. Now, something about genesis of pandemic and the epidemic. How pandemic emerged. So the phenomena responsible behind this pandemic is antigenic shift, which is responsible for major pandemic. Another phenomena which is responsible for today's what we are observing, that is the epidemic or the outbreaks of the seasonal flu. That is another molecular mechanism which is known as antigenic drift. Something about antigenic shift and the pandemic. Again, we have to go back for the knowledge of the viruses. As already I have mentioned, that virus is having 8 different segments. Antigenic shift happens due to the genetic reassortment, means a removal of one segment, replacement of the one segment by another segment. So there is a genetic reassortment. The changes in the genetic segment will take place and it will give rise to the newer virus, which is completely novel virus. That is have antigenically quite distinct property than the previous one. And this is known as antigenic shift. I will go in detail later on. What is genetic reassortment? Genetic reassortment, as already I have mentioned, there is a interchange of the genetic segments between 2 viruses, which takes place in pigs only. And why it is in pig? Because pig is the host, which can consider as a vessel where the virus from the bird and virus from the human can mix, and virus from the bird will donate a gene to the virus of the human, and now the human virus will acquire a newer HA or NA genes, and in turn, the human virus will be changed genetically and completely antigenically uh, as compared to the previous virus. And this is known as genetic reassortment. This is something like that. The avian virus will enter inside the pig. Similarly, the human virus can also infect the pig. Within the pig, the some part of the gene, either HA or NA gene, is inserted within the genome of the human viruses. And whichever new virus is generated, which has an infecting capacity to the humans, but the antigens is derived from the bird, which is completely novel. Hence, it is antigenically different and will introduce into the community a novel virus, which may lead to the pandemic. As I already mentioned, this HA segment, this is a human gene. Now, there are the separate sets of the genes, of the segments of the gene of the human, which specifies the human's host specificity. While the H of this human, perhaps it is H1 priorly, which is replaced by the HA gene, which is encoding, for example, H2, and that is inserted from the virus of the bird. Now, this entire gene is changed due to its change in HA segment of human genome, human influenza virus genome. And this is how this new viruses were emerged. Say, initial outbreak, which was properly characterized, it was a Spanish flu, which was found to be H1N1, and it is presumed that this virus directly entered from the bird. At that time, molecular analysis was not possible, so it is presumed that most likely it is from the birds transmitted the human and troll a large population of the human. Now this after this H1N1 human virus get entry into the pig. H2N2 avian virus this is from the bird, get entry into the pig. Both in between these two, there is a reassortment mechanism took place, and novel H2N2 virus emerged, which is antigenically quite different than the previous H1N1, and leading to the newer pandemic, which is known as Asian influenza. Similarly, after certain decades, a decade or more years, the same H2N2 virus enters into the pig. Another H3 containing avian virus enters into the pig, and there is a development of the genetic reassortment, and new virus emerge, that is H3N2, and it is again antigenically different than the prior one. It is important to remember the H component of the virus, which is present over the surface, which is quite unique, and it defines antigenicity the most. N2, N antigen can also define its antigeny. So either of these two, if altered, then the virus will be antigenically novel. So this is a series of the evolution took place into the human virus. This is a series of evolution took place into the avian viruses. In such a way, the newer viruses emerged and led to the pandemic. Now about this seasonal flu. This seasonal flu virus is due to the same virus which was emerged during the last pandemic. But there are the minor antigenic variation took place, and this is due to the mutations. Say for 2 or 3 mutations, which alters the some part of the antigen of H antigen or N antigen that are known as antigenic determinants. So some part of the H and N antigen will be altered, will lead to some or minor changes into this H and N antigens. So the new variant of the human influenza virus developed. This 2-3 mutations may alter its antigenesis certain extent. But what is the difference in between the pandemic and epidemic prone this virus is? As I have mentioned, H1N1 का जो पैंडेमिक हुआ, उसके बाद जो H2N2 का पैंडेमिक हुआ, राइट? तो H1N1 के पैंडेमिक से जो इन्फेक्शन से जो इम्यूनिटी डेवलप होती, the immunity developed due to the H1N1, that is either in a form of the neutralizing antibody or the cell-mediated immunity. They are not able to prevent the infection by H3N2 because H3N2 cannot be neutralized by the antibody produced by the H1. So whichever new strain emerged during the pandemic, these are completely different. So there is no even cross protections, no even minor protections. This is an entirely new virus and it can spread all over the globe easily. While those variants develops due to the mutations will alter the antigens up to certain extent only. So whichever new variant develop, just I am talking here as a variant. You might have heard about the variant in case of the corona. What we have seen in COVID, initially it was alpha, then beta, then delta, then omicron. These are all the variants, and these variants are developed due to the mutation. Similarly, this H1N1, in which due to the multiple mutations, their variants are developed. This H3N2, due to the multiple mutations in H3N2, new variants are developed. In H2N2, in influenza B also, due to the mutations, new variants are developed. So here the new variants which are developed, which are antigenically, some kind have differences as compared to the previous pandemic virus. Just like in what we observe in COVID. In COVID, the new subvariants develop of the Omicron. They may spread. They may spread because they are antigenically different. But those persons who have prior infection with the Omicron can have cross immunity, a partial cross immunity against the new strain, new variant. Similarly, in H3N2, for example, in a case of the current outbreak, they are antigenically different. But those persons who are infected with the H3N2 priorly, those who are vaccinated, can have a partial immunity against it. So herd immunity due to prior outbreaks can give partial protection and prevent spread at a large scale. That's why we don't observe huge pandemic in case of this variants developed to the antigen drift. I hope it's now very much clear that what is antigenic shift and how it leads to the pandemic strains, and what is antigenic drift and how it leads to the some epidemic or outbreak prone strains. Epidemic antigenic drift, the seen in previous pandemic strains of the influenza virus, type A, H1N1, and H3N2, in which we observe it's quite common. So resultant outbreaks, they are usually the small outbreaks, some periodic epidemics of the seasonal flu, what we observe at every 2 to 5 years. Seasonal flu, as I already mentioned, now I'm talking from the another aspect. The seasonal flu is derived from antigenic drift in pandemic strain. Approximately 5 to 15% of the total global human population get involved annually. As mentioned, I have already mentioned, this drift takes place at every 2 to 3 years or 2 to 5 years, leading to the new variants developed at 2 to 5 years. But because it can spread globally, at certain part, the new strain leads the epidemic here. After 1 year, it will lead epidemic in another part of the world. So throughout the year, at every year, in a particular season, we observe the outbreak of this newly developed variants, and it will affect almost 5 to 15% of the global population every year. Now, till now, what we have discussed, that is a pandemic strain, H1N1, H3N2, H2N2, and epidemics due to the variants of this pandemic strain. Side by side, I would like to mention something about the some avian flu strain which we have suffered from certain small outbreaks by this avian flu. What is it? It's avian flu strains. Actually, it's a bird flu strain only. It's a not human strain. But when they causes a infection, the mortality is very high. It's more than 50%. Transmission only from birds to human. There is a no human to human transmission. So that's a better part for us. So that spread is limited. So only this virus can transmit it from the poultry. You might have heard that the certain area of the world, the poultry, all this hens and the poultry, they have to just completely they kill them because they do not want the transmission from this birds to the human. Certain examples like H5N1 we have seen in India, in Indian poultry, this virus is prevalent. So periodically from birds to human transmission has been observed in H5N1. H7N7, this Netherlands, H9N2 in Hong Kong, H7N9 in China. Remember, these are all bird strain. These are all avian strain, and there is no epidemic or pandemic human-to-human transmission observed in all these strains. So this was about virus. Now, what happens in a human body? They get entry into the human body by the inhalation of the respiratory droplets, large droplets. Unlike COVIDs, they are transmitted by the large droplets, which can transmit up to the 1 meter of the range of this coughing and sneezing person only. Or other way of transmission is through contaminated fomites like handkerchief, pillow cover, bed sheets, or mobile, which are shared, right, which contains the droplets and which, if directly come in contact with the mouth or nose. Again, I am emphasizing that it's an envelope virus, so can easily decontaminated with soap and other disinfectant. Fortunately, the COVID, this influenza, these are all envelope virus. So it's a fragile. It can be easily killed by the various disinfectant. After entry, because HA is a specifying its antigenicity of the virus, it is the main part of the virus which helps the binding of the virus to the human epithelial cells. The receptor of human epithelial cells is a sialic acid receptor, which is present mainly on the superficial mucosal layer of the respiratory tract. Then, after binding to the sialic receptor, virus will try to enter inside the cell. Neuraminidase is an enzyme which is having activity over the sialic acid as well as over the mucin. So it will help the internalizations of the virus into the cell. After multiplication of the virus into the human cell, virus will release, the progeny virus will released by the budding from the cell. Again, Na will help release of the viruses as well as a spread to the adjacent cells of the respiratory tract. So on, the multiple cells of the respiratory tract will be involved. There will be viral multiplication, result in inflammation because virus infected cell will induce some sort of the inflammations. So lysis of the cells due to the viral multiplications or due to the inflammation will lead the desquamation of the superficial layer. Again, desquamation of the superficial layer will expose the underlying layer of the respiratory tract and it will lead to secondary bacterial infection. Now, something about sialic acid receptor. This is the site from which the virus get entry into the human cell. So it is very important. Sialic acid receptor, we are not going detail about the molecular structures, but two things are very important to remember because it defines the host specificity as well as the severity of the disease and the site involvement. One type of the receptor which is known as alpha-2,6 sialic acid receptor, which has affinity with the very limited HA antigens, and particularly the human strain of the HA antigens, they have high affinity for alpha-2,6 sialic acid receptor, and they are in a large number in a upper respiratory tract, while they are absent in lower respiratory tract. So H1 as well as H3 has a higher affinity with the alpha-2,6 sialic acid receptor, which are present only in upper respiratory tract. And that is why in H1 or in H3 category of the virus, predominant involvement is upper respiratory tract and lower respiratory tract involvement is very rare. Another type of the sialic acid receptors, they are alpha-2,3 sialic acid receptor, which are found in a large number in bird's intestine. but they are in a very few numbers in upper respiratory tract as well as lower respiratory tract. That now this 2,3 Celic receptors, they are having affinity for all kind of the H antigens. So all type of the influenza viruses can bind this one, but because they are very less in upper respiratory tract, so only so those H containing viruses which do not have a good affinity for 2,6 receptor, which has affinity only with the 2,3 receptor, they are very less infective to the human being. And that is why the certain bird strains, they are less effective on the or less infective for the human. But once they get entry, they can also involve the lower respiratory tract. That is why in avian flu, the involvement of the lower respiratory tract is more. While birds' intestine contain abundantly this 2,3 sialic acid receptor, so all kind of these viruses can enter inside the bird's intestine and can multiply there. While we are talking about the pigs, it has both a type of the receptor abundantly in respiratory tracts. So that's why they invite the viruses from the human strain, they invite the viruses from the birds, and that's why they invite the recombinations and genetic reassortments of the birds and human viruses within the pig's respiratory tract, and they lead to development of the pandemic. So this is the basic thing why certain viruses are more common in human, certain viruses are more common to cause a lower respiratory tract infections, and why this majority of the viruses are leading mild infections into the human. Clinically, Dr. Vipul will discuss in detail about that. But as already I mentioned, majority are restricted to the upper respiratory tract. Complications observed, but the mainly complications due to the secondary bacterial infection. Lower respiratory tract can happen in even H1N1 and H3N2 lower respiratory can occur because certain 2,3 Celic receptor are present in lower respiratory tract. They go and bind to that and involve lower respiratory tract. But because they are in very less number, less likely they will involve the lower respiratory tract. So lower respiratory tract involvement is mainly due to the secondary bacterial infection. Complication could be worsening COPD or very rare extrapulmonary complication is observed. For laboratory diagnosis from microbiology perspective, I would like to say it is not recommended for the patient management in uncomplicated upper respiratory infection. But whenever it is recommended, nasopharyngeal swab is ideal. From this nasopharyngeal swab, we are detecting the gene of this specific virus. We detect the type A specific gene. From H1N1, we are detecting the H1 genome. For H3N2, we are detecting H3 genome. For type B, we are detecting it's a type specific gene. So there are the certain multiplex PCRs in which in combination of these three or these four can be detected. One technology is available which is known as biofire film array respiratory tract panel, in which we can detect almost 20 different respiratory pathogens, including COVID, this type A, type B, or H1N1 or H3, as well as certain adeno. But it's quite costly. Very few points about the antiviral treatment. Two options we have. One is neuraminidase inhibitor, that is like oseltamivir, which has a good activity against H1N1, H5N1. In H3N2, the matrix protein inhibitors like amantadine perhaps had a less activity, but it was observed in 2016. In present strain, we don't know because certain clinical data may come. But in 2016, it was observed that 95% H3N2 strains are resistant. And at a last slide, I will just highlight about the immunity. The immunity protecting against these viruses, they are mainly neutralizing antibody, which is B cell immune response. After infections, neutralizing antibody against HA and A antigens are developed, which prevents the infection. Cell-mediated immunity also play a very important role in a lysis of the virus-infected cells, so that further propagation of the virus will be prevented, further multiplication of the virus will be prevented, as well as help into the disease cure. And the last point, the selection pressure from the immunity due to the prior infection or the vaccination helps in extension of the old antigenic variants and emergence of the new ones, what we observe. In short, the once whenever there is a pandemic or the seasonal flu, whenever there is a spread of the one kind of the viruses, for example H3N2, once it is a spread, there is a herd immunity develop against the H3N2. But after the series of the mutation, if some H3 will be altered, new strain will emerge, new variant will emerge. This existence will be favored by the selection pressure by the immunity developed due to the prior exposure. So prior exposure mediated immunity will lead to the extinction of the prior variants and emergence of the new variants developed due to this antigenic drift. So thank you very much.
Thank you, Urvesh Bhai, for a nice and elaborate pathogenesis of this seasonal flu and all viruses. What we learned that these type of viruses are like phoenix. Once we finish the older phoenix, the new phoenix emerges from another viruses. Now, next session is of Dr. Vipul Bhai. It is about the clinical, the perspective of this flu. Where Vipul Bhai, everybody knows and doesn't need any introduction. He's having his clinic at Sardar Mandir Char Rasta and having this infectious disease practice. So directly over to Vipul Bhai because of short of time.
Thank you, Daba sir. At the outset, I would like to thank FFPAI and College of General Practice, sir, IMA, for giving this opportunity. Almost many things in the basics of the virus has been covered by Urvesh Bhai. I would like to touch upon the clinical aspect because more of the general practitioners, they are interested in managing the patient in day in, day out practice. The key facts regarding the current H3N2 epidemic is basically influenza type A viruses are most of significance to the public health because they are known to cause pandemics. Humans can be infected with avian, that already mentioned, the swine and other zoonotic influenza viruses. Depending on the origin of the host, influenza A viruses can be classified as a avian influenza, swine influenza, or other type of influenza viruses. The examples already mentioned by Urvesh Bhai, bird flu, that is what is known as the avian influenza virus. There are certain subtypes like H5N1. Similarly, swine influenza virus, we all know regarding the H1N1 and the H3N2. Currently circulating in the humans are subtypes A-H1N1 and A-H3N2 influenza viruses. These are already been discussed, so I'm skipping the structure of the virus, the two important antigens. There are 18 H antigens and 11 subtypes of the N antigen, leading to the combination of different influenza A viruses. This is in short one slide, the pathophysiology of the viruses. Viruses attached to the H antigen, goes into the host cell, DNA, then start accumulating the material of his own. Then with the help of the neuraminidase receptors, they comes out of the body to infect the other cells. This is the history basically. If you look at the history, every 10 to 20 years, almost 10 to 12 years or 10 to 20 years, there is some sort of pandemic by influenza A viruses. And what in 1968-69 already mentioned that H3N2 led to the moderate pandemic. The current scenario by a swine influenza A H3N2, according to the latest data available on Integrated Disease Surveillance Program and Integrated Hospital Information Platform, a total of 3038 laboratory confirmed cases has been detected by caused by influenza viruses, including H3N2. And about half of the patients of the severe acute respiratory infection and outpatient clinic patients, they are caused by H3N2. So these are the diagnosed confirmed cases. If you look at the number of cases which has not been confirmed by a laboratory test like a PCR, there are a lot of cases which has not been diagnosed. So this is the tip of the iceberg, what we are confirming and giving the number. Coming to my main topic is how the patients comes to you and how should I manage the swine influenza A, H3N2. Usually, as already Urvesh has said, the H3N2 current seasonal flu is basically a very mild in nature and usually recover within a week. Mostly they cause URTI, but some small number of patients, they develop severe illness, in particularly a group of patients, those who are high risk. And already Ministry of Health and Family were already updated that these subtypes causes more hospitalization than other influenza A subtypes. So there might be some sort of antigenic drift which has led to the increased number of human influenza A H3N2 cases, as well as more and more transmission. And that may be because of some sort of changes in the mutation, which has led to the more hospitalization and more little bit severity as compared to other times it has been caused. Looking toward the symptomology, it's as usual as caused by other seasonal flu like fever, sore throat, runny nose, cough, headache, weakness, fatigue, aching of the muscles and joints, vomiting, diarrhea. Let's go a little bit detail in the symptomatology because it is very important. If you look at the fever, it is usually abrupt in onset. Usually patient says that yesterday I was absolutely fine. Even in the morning I was fine and after 1 hour I had a high grade fever. So these are the usual symptoms, that abrupt onset of the fever, and within 24 hours, it's starting from the 100, it goes to 104, 105 degree temperature. Usually the fever subsides by 3 to 5 days. In current scenario, we are seeing sometimes 5 to 7 days to settle down the fever in case of H3N2 viruses. There is no rigors, usually it is with mild chills and cold. The headache usually found in frontal and periorbital region, which is again a very important characteristic to differentiate the influenza. Myalgia, any part of the body can be having a aches or muscle pain, but the legs and backs are predominantly affected. There may be mild arthralgia. The conjunctival suffusion, we have seen in this type of H3N2 this year or this season, the H3N2 infection, some sort of conjunctival suffusion is more common as compared to other seasonal flu. And there is a disproportionate weakness. So if the patient having 101 temperature, but the weakness is extreme, which likely we found in a dengue type of viruses are also found in H3N2. The respiratory symptoms, they are very common and usual as found in other seasonal flu, like runny nose, sore throat, substantial discomfort, usually dry cough. In this type of this season, where we are finding H3N2, the important differentiating point from the other flu is that the cough, which is dry and lasting for 2 to 4 weeks. Usually, in other flu type like seasonal flu, it goes within a 1 week or 10 days, cough subsides. But this, like H3N2, this type of this seasonal flu, we are finding out that a patient complain of dry cough for more than 2 weeks, 3 weeks, even 4 weeks. And there is a severe pharyngeal inflammation on examination of oral cavity. If you look at can we differentiate between the COVID-19 and H3N2, which is a demand because now the government and all the media says that even the COVID-19 cases are increasing. It is very difficult to differentiate between COVID-19 and H3N2 influenza viral infection, particularly in case of upper respiratory infection. But there are some points which may guide you. Like symptom onset usually abrupt in H3N2, while it is acute in COVID-19. The cough, as I already said, is a severe and long-lasting in H3N2. The muscle pain is more of weakness in H3N2 than COVID-19. And definitely loss of taste or smell is more common in COVID as compared to rarely found in H3N2. The complications, we had seen as a super specialist, we had seen patients, those who are coming with the complications. And we had evident H3N2 directly causing viral pneumonia. It is similar to a community-acquired pneumonia, not a secondary bacterial infection. It is a primary viral pneumonia. It can cause defense mechanism to go down and lead to secondary bacterial infection and pneumonia. It can cause ARDS. It can cause exacerbation of COPD and asthma. And there are certain extrapulmonary complications. In this season, we had seen almost 2 patients of myocarditis, which has been directly because of the H3N2 virus rather than other cause. Ray's syndrome is basically known phenomena since many years. If the children less than 18 years of old, if they has been given aspirin for either fever or headache, in a case of influenza, it may lead to severe acute hepatic necrosis and liver failure, which can lead to death even. Certain myositis and rhabdomyolysis, when there is a predominantly muscle involvement, which may lead to the acute renal failure. Myocarditis and pericarditis already I mentioned. And sometimes patient may have a encephalopathy as well as acute transverse myelitis and Guillain-Barré syndrome. Laboratory diagnosis is a very easy to isolate the virus by either PCR or viral culture. Viral culture is done only in a research lab. So we have a diagnostic test as a PCR. Material already been mentioned by Urvesh Bhai, either nasopharyngeal swab, throat swab. We can do a tracheal aspirate in case of patient those who are in ICU with a tracheostomy. And one slide regarding the rapid influenza diagnostic test. This has been asked by many practitioners. Can we do or apply these tests, or it is available here or not? The rapid diagnostic test basically are having a lower sensitivity as compared to RT-PCR, and reliability depends largely on the condition under which they have been performed. And commercially available RT-tests in general cannot provide a subtypes. So for us, it is usually useless. So we have to diagnose only by a RT-PCR, either in the form of single RT-PCR, multiplex RT-PCR, or biofire, which has been already mentioned. Treatment of uncomplicated influenza. Uncomplicated influenza means what? Either mild type of URTI, that is what is known as an uncomplicated influenza. Usually it is a symptom-based treatment. For headache, fever, or myalgia, you can give paracetamol or even acetaminophen. For those who are having running nose and nasal blockage, then you can give decongestant. No aspirin to children less than 18 years. If there's a cough, you can try dry coding and avoid smoking. For sore throat, you can use lozenges to soothing the trachea and upper septic. Most importantly, ask the patient to maintain hydration. Particularly, many times patient having a weakness, they don't take much of plenty of fluids, and which lead to the more aggravating features of influenza. So maintain hydration, ask the patient to have a plenty of fluids. And the full activity has to be returned very gradually rather than suddenly. Specific antiviral treatment is used only on a subset of patients, which I have been mentioning later on. But there are evidence that antiviral drugs, notably the neuraminidase inhibitors like oseltamivir and zanamivir, can reduce the duration of symptoms and improve the survival. So definitely has to be used in a certain group of patients. In suspected and confirmed cases, whenever you are using the neuraminidase inhibitors like oseltamivir or zanamivir, preferably use within 48 hours. So it has a wonderful response. As the day passes, it can be used, but the effect is decreasing, and can be given in admitted patient even after 48 hours because they are very severe or sick. And treatment usual duration is 5 days, but can be extended until there is a satisfactory clinical improvement. Oseltamivir is basically available freely in both the forms, in the form of capsule as well as syrup, and can be used according to weight. For adult patient more than 40 kg, is 75 mg twice daily doses. Side effect, basically a GI intolerance is the major side effect. Patient might present to you with a nausea and vomiting with the oseltamivir. Sometimes it can cause bronchitis, and very rarely sometimes cause angina or rarely anaphylaxis. Zanamivir is basically another drug which can be used for the H3N2 influenza A or any other influenza A viral infection. It is available in a form of rotacaps. So it has to be taken with the rotahelor. So 10 milligram, it is available in the 5 milligram capsule. So 2 rotacaps of treatment to be twice daily, and same for the 5 days. Both the drugs, oseltamivir as well as the zanamivir, can be used for the prophylaxis. That I will come to later on, how we can use prophylaxis. Can we give antiviral drug to all the patients of influenza A suspected or confirmed H3N2 viruses? No, there is no clear-cut guidelines. So many times the general practitioner, or even the practitioner, they ask question, should we give all the patients we suspect influenza virus? What I usually stick to the previous H1N1 guidelines. Then if there is a mild patient, doesn't require any treatment, it is a self-limiting disease, and majority of patients, they recover within a 7 to 10 days. In moderate to severe patients, yes, you are justified to prescribe the oseltamivir as well as zanamivir. And we can extrapolate the H1N1 guideline, which we have already, till the new guideline comes from the government regarding the curtailing the H3N2 and the use of oseltamivir in this current seasonal flu. We can stick to the H1N1 guideline and extrapolate for the H3N2. Like, what is this guideline? It guideline categorize the patient to 3 different categories. The category A basically a mild symptoms, mild fever plus cough and mild sore throat without any major complications. They do not require oseltamivir and should be treated for the symptomatic treatment, and patient recovers within 7 to 10 days. But this type of patients has to be monitored very carefully. So in a general practice, you ask the patient to call you every day regarding his symptoms progression. If the fever goes high and high, if the patient develops some complication, then you are justified to start the drugs immediately. Patient can isolate or patient can restrict their activity to the home and avoid the mixing of the family members of community to prevent the spread of the infection. The category B is divided into 2 parts, B1 and B2. B1 is nothing but category A plus high grade fever or severe sore throat. So this is category B1, and you are justified to start oseltamivir or zanamivir, either of drug, and ask the patient for the isolation. Category B2 is basically a high risk population. So any patient who have a mild symptoms, but those who are more than 65 years of age, those having a chronic lung disease, heart disease, kidney disease, uncontrolled diabetes, neurological problems, HIV, those who on corticosteroid therapy, these are the high risk group of patients. Even if they develop mild symptoms of influenza, current influenza H3N2, then you are justified to start oseltamivir. Category C is basically a severe illness which requires hospitalization. Those patients who are having a influenza H3N2 with breathlessness, chest pain, drowsiness, hypotension, hypoxemia, tachypnea, chest infiltrate, evident on the X-ray or even CT scan. These are the group of patients which requires immediate hospitalization and starting the antiviral specific drug. Coming to the prevention part, just 1 or 2 slides. Vaccine, there are a lot of questions regarding the vaccine, currently available vaccine. Can it prevent the H3N2 or not? The vaccine which are available in the last 3 to 4 months, like 2020-23 strain, I'm not giving the name because of the confidentiality purpose, but there are vaccine available which can prevent the H3N2 infection. But this is a little bit too late. Already seasonal flu has been rampant. So if you take this vaccine today, it will take antibody to develop 2 to 4 weeks. Till that time, you should not have while taking the vaccine, you should not have a flu-like symptoms. And probably, if it doesn't go into a important mutation, like this H3N2, if remains same strain, it will by the end of March or by the end of April, start of April, it will vanish. But if it goes in another mutation, which can lead to the novel virus or something different virulence, then it may be a different scenario, which is less likely. But it has to be keep in mind. So currently, vaccine available, they say that they covering the H3N2 current seasonal flu, so it can be useful. But till we go into the detail of the genomics, it is very difficult to say that all the vaccines to be given to all the people or not. But yes, vaccine is available. Vaccine covers H3N2 virus. Like 2 or 3 vaccines are there which cover the H3N2 virus. That can be taken usually in every yearly single dose, intramuscular 0.5 ml, usually taken in a deltoid region, and it can prevent after 2 to 4 weeks the H3N2 viral infection. The prophylactic antiviral drug, like those patients who are in close contact with the confirmed H3N2 seasonal, like influenza A viral infection, they can be given oseltamivir or zanamivir as a prophylactic drug, those who are in a close contact. Like oseltamivir to be given in a single daily dose of 75 mg in adult patient for 10 days. So for prophylaxis, it is 10 days but single dose. For treatment, it is twice daily for 5 days. Similarly, zanamivir to be taken in a single daily doses for 10 days. So these are the prophylaxis as an antiviral drug can be used in a close contact patient relatives. Non-pharmacological measurement, that is very important. That we already know that is an airborne infection. Large droplet produced by sneezing or cough can infect the person, and hand-to-hand contact with infected person and touching to the nose and mouth. So big droplets fall on people's surface and break clothes. So what is the recommended do's and don'ts in this current scenario? Avoid close contact of those patients who are having a symptoms like influenza. Keep distance from the infected person. If possible, stay at home, away from work, school, and public places. When you are sick, cover the mouth and nose with a tissue or handkerchief when coughing or sneezing. If no tissue or handkerchief is available, then just while coughing or sneezing, put your clothes or sleeve of the shirts over the nose and mouth. Even it can prevent the spread of the virus. Washing the hands with the soap or any alcohol-based hand wash is sufficient to kill the virus from the surface of the hand. Get a plenty of sleep, manage your stress, drink plenty of fluids, and eat nutritious food, which can build up your immunity. Wear the face mask while roaming in the community. Again, after the COVID has gone down, we have now been liberal in our OPDs, even in out settings, that we are going or roaming without any mask. Now again, seasonal flu has reminded us that it can be useful even normal condition also. So wear the face mask as possible in the community. Use handkerchief or tissue to cover while coughing, sneezing. And lastly, the last slide, the 3 C's are important for the prevention, particularly clean. Wash your hands very regularly. Cover your mouth and nose while coughing, sneezing, and contain yourself once you get the influenza-like symptoms. So this is in a nutshell how I will manage in current scenario with the best possible way of influenza A, H3N2. Thank you.
Thank you, Vipul Bhai, for a nice and elaborate clinical insight to this flu virus and H3N2 and all that. Now, I think we'll go for the question and answers. There is one question that the immunities can be primary or secondary. This primary can be because of the influenza virus itself or maybe secondary bacterial infection.
As I already mentioned earlier that yes, virus can directly cause viral pneumonia. And we had seen the patients, those who are having any secondary bacterial infection, just normal count and on a third day of fever with normal count, lymphocyte predominant, and all upper respiratory infection as well as lower infection with a confirmed pneumonia case on a CT scan, having just giving the antiviral drug and patient recover. So yes, it can cause directly primary viral pneumonia, and there may be a secondary bacterial pneumonia. Usually what happens that in URTI cases, after the first fever of URTI, then the fever subsides. So the viral infection subsides. Then after a few days, again the another spike of fever usually comes with high WBC count with some sort of cough sputum. That is usually the secondary bacterial infection where you are justified to use antibiotics. Otherwise, many of the patients directly go to the counter, over-the-counter medication. They are giving the azithromycin as well as some other antibiotics for mild typical upper viral URTI, which is the problematic. So avoid and educate your patients that this is a classical seasonal flu. These are the symptoms of viral URTI. So don't take antibiotics upfront. If your fever subsides and after a few days, again fever starts, then we will look into the matter and we will give you some antibiotics.
Thank you. The next question is about vaccination. Routinely, for this viral fever or any flu, we do not go for this flu, any RT-PCR about this H1A. But suppose if we want to prescribe, you said that there are 3 types of tests is being carried out. Can you tell us which test is to be carried out when and what is the cost of it?
Actually, for diagnosis or specifically if you are suspecting the swine flu or it is whenever there is this situations like outbreak, we may go for the nasopharyngeal swab PCRs. But as mentioned, in uncomplicated cases, there is a no role. It has a 2 role only, diagnostic in severe cases or in an epidemiological study or the surveillance by the government. So for that nasopharyngeal swab, ideally should be transported into the viral transport media, and for that you need to go for multiplex PCR, which targets influenza A, B, and H3N2 as present, and H1N1. Priorly in BJ Medical College, what we have started the influenza A and H1N1. If influenza A positive and H1 positive, that's okay. If influenza A positive, H1 negative, then it was considered H3N2. But nowadays the kits are available to detect H3N2 as well, in a single kit only. So you can go for this. While the BioFire, it's detecting 20 pathogens, and it's quite costly. So only if you are suspecting some other like adenovirus or something you want to analyze further, then only you should go for that thing. Otherwise, multiplex for H3N2 and H1N will be okay.
Regarding
Suppose,
cost,
suppose,
the cost of multiplex, that is including influenza A, H1N1, D, and H3N2 is around 4,500 rupees. COVID testing in private, they are doing around 400, 500 rupees. And BioFire is around 16,000 rupees, which include 20 pathogens. I think it is correct. Is it correct, Urvesh?
Yes, definitely. But this is around charges.
so next,
As in COVID, we are seeing that the AIDS, which is mostly fatal in too many cases, is due to the catastrophic storm. So, does in the patient with immunocompromised, they are more safe, like HIV positive or patient on long-term steroid, as they have a low immunity, so they less react to these agents and go into AIDS. Is it like that?
Actually, here I would like to mention that that was a cytokine storm which we are talking about during in
Yes.
certain strains of the COVID, which was observed. It's not a pathogenic mechanism observed in Haemophilus. In this influenza. In influenza, we observe the rise in some cytokines. CRP also rise, certain cytokines also increase, but there is mainly directly related to the inflammatory condition led by this influenza virus. And more so, the viral direct pathogenesis, direct involvement of the cells and the inflammation, and sometimes secondary bacterial infection is the condition leading to this some motile condition.
now next question is about the city. HRCT of COVID patient and HRCT of this H3N2 patient having pneumonia. What will be the difference in HRCT's findings?
Yes, there are no HRCT criteria to differentiate between the COVID-19 and H3N2 or even H1N1. But by experience, what we had seen particularly that in a COVID, particularly when there is a cytokine storm, like COVID leading to ARDS or H1N1 leading to ARDS or H3N2 leading to ARDS, it is same. Nothing has been changed or different in the points in the HRCT. But yes, when in the COVID, we had seen or we had observed when there is a cytokine storm occurred, which is due to the typical ground glass opacity and what the scoring system was there, that was not observed in a H1N1 or even H3N2.
Now the next question is from one doctor.
Yes.
That ideally vaccine in India, at which month we should take, first thing. And second question is mine. See what I learned is antigenic shift and antigenic drift. I think vaccine will help in cases of patient the flu which has because of antigenic shift, and I think a vaccine will not help in case of flu which are because of antigenic drift. Am I right?
Exactly. Antigenic shift will give rise to development of entirely new strain. So one vaccination against this prior strain, if it is given, this vaccination will not prevent the emergence of the new strain which is developed due to antigenic shift, because antigenic shift will give rise to the totally a new strain. While in antigenic drift, again, there are the certain variants which is developed due to multiple mutations which can escape the immune system of human who have vaccinated priorly with these prior strains. But partial immunity can have with the vaccine. For example, right now, whichever vaccine is available, whichever taken in the last year, can give partial protection against some new variants emerged due to the antigenic drift this year. But it will be the partial because it is antigenic drift, it will be the partial. While new pandemic strain due to antigenic shift cannot be prevented by the vaccination.
And
Here,
in which
just
month?
one more thing, sir. When I was going through the seasonal variation, what are the reasons for the seasonal variation? So it's a very complex, but it is true that the seasonal variation is evident since a century. It is always seen in a season of winter. So I think before winter, vaccination is taken. October or November. If covering a new strain vaccine available, then it is better.
Yes.
Vipul bhai,
Yes,
I think
absolutely.
initially we
Yes,
were recommending
yes.
July,
Yes,
August.
basically, there are two important seasons for the influenza in India, particularly what we are talking about our country. First is post monsoon. So during the August, September, October, this is the season where the influenza cases rises. And the second season is winter, like this, like December end to January, February. So these are the two important seasons where the influenza cases rises. So ideally, usually what happens, the new series of vaccines they available by end of August or starting of September. So during that time, it is ideally to take the vaccines. So before the post monsoon influenza surge coming up, you are getting vaccinated. You are having protective antibodies, and that antibody will continue for at least 6 to 9 months or even 12 months. So even the winter season, you will get protected. But for the next year, again you have to take the another flu shot of vaccine because the antibodies again goes down gradually.
Now, next question is from one doctor that suppose a patient is having secondary bacterial pneumonia following this flu, which antibiotics should be preferred or should go for sputum culture?
Again, for this H3N2, this season infection, we don't have a much evidence data particularly, but yes, if you look at the H1N1, is almost similar to H3N2 leading to the problems. So at that time, the gram-positive infection, Staph aureus, and in fungus, the Aspergillus. These are the two important organisms which are likely to cause the secondary bacterial infection predominantly. So definitely, you should go for the sputum culture and sensitivity, no doubt about it. But till the sputum culture and sensitivity comes to you, any standard cephalosporin or even penicillin beta-lactamase inhibitors can be useful for covering the Staph aureus. Unless the patient having a severe comorbid condition, patient is already taking multiple antibiotics in last 3 months, multiple hospitalization in last 3 months, then it is a different scenario. But otherwise, any BLI, or even cephalosporin can lead to sufficient for the secondary bacterial infection. And definitely you should go for the sputum and culture sensitivities and accordingly they change it.
Can I add one point to this, sir? For an antibiotic, usually what happens, as Vipul sir rightly said initially, the initial viral infections, there is no need of the antibiotic. Rather, giving antibiotic is causing some harm. By what mean? Just I am explaining that if the viral infection process is going on, it causes the discrimination. So it will expose the underlying area for the bacteria. If from the beginning you are starting the antibiotic, see, no mucus lining will remain bare. It will be colonized by the some organisms. You start the antibiotic, definitely the resistant organisms start colonizing that mucus area. So whenever there will be secondary infection, it will due to the resistant organisms. So at that time, it will be very difficult to treat. So no use of the antibiotic at the beginning. Otherwise, it will lead to the secondary infections possibly by the resistant organisms. And in addition to that, perhaps this year we have observed certain cases of the streptococcal and the moraxella as well for secondary. So we don't know the exactly the clinical scenario is what, but the heavy growth of the moraxella and streptococci pyogenes we observe in case of the confirmed case of the influenza. So it could be some possible for secondary bacterial infection. So, सर दरबार सर अनम्यूट करવું પડશે.
Okay. Now almost all the questions are over. So thank you, Urvesh Bhai and Vipul Bhai. A nice insight, clinical as well as pathological about this flu and H3N2. Thank you all. And now we are now ending the session.
Thank you. Thank you very much, all. Thank you very much, all.